Welcome to the DRH show. Today I'm joined by an intensive care physician, Dr. Joseph Layon. Thanks for joining me.
Hey, Dennis. Hi. Thank you. And as we you can call me Dr. Layon if you must because it's formal. But if I'm going to call you Dennis, you may certainly call me Joe. Not a problem.
Okay.
All right. What do you want to do, my friend?
Yeah, that's perfectly fine. But of course, you're a medical practitioner. Let's kick this off with you telling us your medical background, your trajectory in life, and how you ended up doing what you're doing.
Well, I thank you. As they say, I started out as a child. I grew up in a with a family of the grandson of immigrants from the Middle East, um, in a place in Southern California that is considered so, or was considered so conservative, it was almost another country. I was not on any trajectory to do medicine ever. In fact, I built cars, I raced cars, I was uh, uh, just a typical kid of the 60s and early 70s. And then one day realized that this was probably not a good way to live a life. And people who I loved and loved me offered me their hand. And I went up to San Diego and started trying to go to college. It was literally trying at first. I'll never forget the first paper I ever wrote in an English class. Was full of red ink corrections with a good D minus. So I didn't know how to write when I first started. I guess I can write now. Anyway, at one point in taking a philosophy class, one of our professors, a wonderful guy, hopefully still alive, a guy named Paul Wheatcroft, said, and this is now 1971 or 2 or something, what does it mean to live a life that has meaning? And I had thought about medicine, and that in that moment, it struck me that medicine was the way to provide meaning in the life. And so the trajectory after that was set. I finished this at a junior college I was at, went to University of California, San Diego, a wonderful, wonderful place. Went to University of California, Davis to medical school. And then at the end of medical school, 10% roughly of my class of 100, 12% something, we all went to a place in Chicago, Cook County Hospital in Chicago, which was at the time known as the People's Hospital. It's a place that was a big public hospital, served African-American, Latin, white people, but basically all folks who had no other options for their health care. And that was the place that we all chose to go. I'll never forget when I mentioned to somebody that I had matched at Cook County, they said, "Oh my God, I'm so sorry." And I said, "Why would you be sorry? That was my number one choice." And in fact, it was a wonderful place to be. I took some time off of my residency and worked in Latin America in 1980 and 1981. Came back just in time for the AIDS epidemic, which is a story in and of itself, unfortunately. Had fallen in love with critical care medicine while I was in Latin America, and then ended up at the University of Florida, where I did a second residency in critical care medicine and spent 28 years there before getting recruited up into the Northeast. And so that's sort of what I had done. In the midst of all of that, death and dying in critical care with HIV, now with COVID, is a daily part of life in the ICU. And so it's one of the things that one would think about a fair amount, and I have thought about a fair amount prior to writing this book.
And of course, this led you to writing your most recent book, A People's Guide to End of Life. And actually, that's one of the reasons why I invited you to the DRH show to explore more about your book. So, Dr. Layon, tell us what prompted you to writing this book, A People's Guide to End of Life.
Well, I had always. Well, let me rephrase it. There was a number of fairly sticky situations when patients I was caring for were dying throughout this roughly 40-year period we're talking about. And I had always thought that it would be a good thing to spend some time to try and put onto paper some guidance, not for physicians as much and nurses, because that guidance does exist. But for families, it seemed that families just, they were lost. But I had never done it. I had, for a number of different reasons, a little extra time in 2018, 19, and and the a friend called, whose husband, we had socialized with him. Her husband was a professor and was dying, and she was bereft. She didn't know what to do. She was lost, and so she asked me to come talk to her, talk to him, and it was in the context of that conversation when this woman turned to me and said, "This was helpful. You really ought to think about writing this down." And it sort of hit me like, why had I not? I mean, of course I'd thought about it, but why had I not done this? So I sat down and around 2019 and started outlining what this book might look like. And the result is what exists today. That was the impetus. But there's of course 30 or 40 years worth of work that led me to that position.
And of course, Dr. Layon, what we're talking right now is one of the toughest subject, perhaps. Death is a tough subject for everyone, and it's inevitable. But I suppose what makes it even more difficult for some people is that they have to deal with, a family member or friend, perhaps, who are critically ill or perhaps placed in a hospice. So from your experience, can you explain what this process involves and how does loved ones navigate throughout this process?
Well, you're right, Dennis. I mean, of course, it's difficult. I mean, how could it not be difficult? And there's no way to make it sort of easy, but there are ways to make it better, I think. So it's a tough subject. One of the central issues is the whole question of what I call in the book navigation and situational awareness. You have to know where you're going and where you've been. And you have to know what's going on around you. Part of the challenge that we have in the States and in the United States, and I would say parenthetically, I've worked outside of the country a fair amount in the Middle East, Turkey, Greece, Central America for sure, and done visiting professorships in a handful of places in Japan and Europe and so forth. And I've always sort of asked about this question of death and dying. It really does seem that in the U.S. we've got, even if it's inchoate, an attitude that we just don't have to die. It's optional, almost. I mean, I know that's absurd to say, and no one would actually say that, but it appears that way, and it appears that way because so many of the people, the patients that I see, have never actually sort of had the talk with their loved ones, with their partners, spouse, whomever. And part of the issue is indeed, where are you going and where have you been? What diseases do you have? Your primary care doctor will tell you what's going on. You know that something is going on. What's the trajectory of that disease or set of diseases? And then what is it that you would want, the patient now, if you were to, as you will, as we all will, become dreadfully ill? What would you like? Do you want to fight to the end? That's legit. Do you want to push as hard as you can until it appears there's limited hope and then stop and be made comfortable? That's also legit. And there's various things in between. What's challenging is when there's never been discussion, and now the patient is dreadfully ill, and the family says, "Do everything, and what precisely is everything? And what that ends up requiring, and it's fine. I mean, it's what we do. It's our nurses, especially the bedside nurses, are the heroes and heroines of death and dying. They spend a great deal of time talking with family and with patients to try and determine what, quote, do everything actually means. And then what happens is together, the nursing staff, the bedside nurse, myself, or my colleagues will speak with the families and sort of lay out what appears to be the trajectory of the disease. And we talk generally in terms of of chances, sort of percentages. It's a little challenging because, of course, if you have a disease, and I write about this a bit in the book, if you have a disease, it carries a mortality of 25%. What that means generally that 1 in 4 people who will have that disease are going to die. But that's if you have a population of 1,000 people or something. But if you have this one person in front of you, he or she either will die or won't die. One of the two. It's not going to be anything in between. It's a 1 or it's a 0. And so you use kind of population statistics to give families and patients, if they're cognizant, if they're with it, some idea of what's happening and the direction that they're going. And then you have to say, we will push as hard as we can for you if that's what you'd like. But you're not gonna have a 25% chance of dying. You've got either overall it's 25%, but you either will or won't die. One of the two. And it's spending time with families like that I think makes things better, not good, but at least better as they navigate this journey. And it is a journey, right? I mean, we are born, we do what we do, and then time passes, and we will all end up in that bed somewhere, dying. And the only question is how will we die? With some dignity or not?
Absolutely. Now, like what you've mentioned earlier, Dr. Layon, you have a wealth of experience. So I would imagine there will be some, snippets of real world examples of cases that went wrong. Could you mention some that perhaps we would expect from your book?
Sure. I mean, there are some examples, though. Some that went well and some that didn't go well. And frankly, some that I think I just screwed up. I mean, really, really screwed up. Not that the medical care was poor, but the way that I handled the person's dying was really not what it should have been. So one of the cases that went well, there was a wonderful guy in the book. He's called the Judge, and he was in fact a judge who I had known and had helped take care of, and he had multiple chronic illnesses. And during one hospitalization, he said to me, Joe, I think I've just had it. I don't want any more of this. I don't want any more invasive anything. I simply want to be able to be with my family, and when it's time, just to die. Can you help me do that? And so I said, well, of course I can help you do that. And most, again, parenthetically, most people from studies that have occurred from the roughly 1960s to date, so 50, 60 years, 70 years, most people, when you ask them, would prefer to die at home in their bed surrounded by loved ones. This has been consistent. But only something like 20, 25% actually end up being able to do that. It's really quite challenging. Hospice has made this easier, but it's still challenging. So with this man, we made a plan, brought all of his family together, all of his kids. His wife had died a couple of years previously, explained what he wanted, and he was able to explain. And when he fell ill again, decompensated, and was now dying, we, the family and I, made sure that he was comfortable and were with him at his bedside as he died. And he, in fact, did die. Could have involved hospice, didn't in this particular case, but he died. And I will never forget, as long as I live, one of the last things he said to me, he was clearly dying. And he said, Joe, is there anything else we can do? And I said, no, I won't say his name, but no, Judge, there's really nothing left to do except show your family what it means to die like a human, like a man, I said, but it's not man. I mean, like a human being. And I will never forget, he looked at me and he said, Joe, I'll do my best. And he did. And he did. He showed his family what that meant. And he died a death of some dignity. Everyone was sad. They loved him. But he died a death with dignity. There was a case, a slightly different case, a guy who had been a Marine infantryman, a uh, profoundly religious guy, a Catholic guy, who had a living will. He said, "When there's, do everything you can to keep me alive, but when there's no chance, please allow me to die." And we had the living will. And this man had come into our hospital literally 6 times in 6 months for the same problem. He had had so many strokes that he was no longer able to handle his oral secretions. Without even thinking about it, you and I swallow our spit, oral secretions. We don't even think about it. This man could no longer do that. And he was getting those secretions, which are contaminated with the bacteria that's in our mouth, into his lungs and developing pneumonia over and over and over again. So when he came back for the 6th or 7th or 8th, I actually don't remember anymore, but multiple times. He had been admitted multiple times in the previous 6 months. I asked that we get a ethics consult, and the ethics committee said, you really need to sit down with his family. So I asked the family to come and that we have a conversation. And because the family was also extremely religious, and they were Catholic as well, I asked a Catholic priest to be present. And so we sat down together. The family was, I believe it was the son was virtual. I think the daughter was present in person, and went over the course in the last roughly year of their dad's situation, and basically explained that he was dying, and that what we were doing to him every time he would come in, we'd put in a breathing tube, and we would get him better. He would leave. He'd go back to the nursing home. He'd bounce back within a month. And that this was not in keeping with his living will. This was not in keeping with even the tenets of the Catholic Church, who say that if indeed you are dying, you don't have to, quote, do everything, unquote. And the Catholic priest who was present basically affirmed that. And the daughter of this man said to me something I will also never forget. You don't understand. Jesus suffered for our sins. I want my father to suffer like Jesus. And I'm not very often speechless, but boy, oh boy, was I speechless. And finally, a few seconds later, I guess, I said to her, well, I didn't go into medicine to make people suffer, and I unequivocally will not do this. I unequivocally will not follow your direction. So, of course, she said, well, then we're going to sue you, and you'll hear from our lawyer. And that was the end of that. Well, and we did hear from their lawyer. And in the one time out of hundreds, I must say, hundreds, it seems like, that I had to go to the hospital lawyers. In this particular case, they were helpful. And they wrote the family lawyer a note. The family lawyer sent us a letter and said, if you don't do what we ask, we're going to sue you. And our lawyer said, be my guest. Do whatever you want. Knock yourself out. We discharged the guy. We didn't have to re-intubate him. We took care of him with non-invasive ventilation, discharged him back to the nursing home, and he died later elsewhere. He never came back to our hospital. That's not a case that went well. And that's not a case that, I don't say any of this to make light of the family or anything. It may sound like it, but I really don't mean it that way. But it was really quite challenging. And it's one of the things that happens when sort of religiosity in this particular case takes precedent over sort of humanity, if I may say so. I wish that had gone better. It didn't go well. There was a third case I'll just mention briefly that I thought went remarkably less well. And it clearly was the way that I handled it. This was a 30-some-year-old young woman who had developed what's called an arteriovenous malformation in her brain. And that's basically where the small arteries do not feed any part of the brain. In this case, it was a arteriovenous malformation in the brain. They can exist anywhere. But it doesn't feed any special part of the brain. It doesn't feed any part of the brain. It just comes into the skull, and then it goes out into veins and then drains back into the venous system. And it's because there's relatively high pressure in that system, there's high risk of bleeding. So what can be done with a especially when it's a large AVM is the neurosurgeons will do a number of procedures, usually more than one, to try and decrease the size of the thing, and then ultimately go in and resect it. They do a craniotomy and resect the arteriovenous malformation. And for this young woman, that's exactly what happened. She literally walked in the hospital. She knew she had this AVM, knew that there was some risk involved with us doing the procedure. Our neurosurgeons did the procedure and did a fine job, and sent her to us in the neurointensive care unit. And one of the things you have to do with these cases is you have to protect, quote, protect, unquote, their blood pressure. That is, you can't let it get too high, because what ends up happening, and this has to do with the way the blood vessels of the brain regulate themselves. When you've got a circuit like the AVM, and it's literally like a circuit that has low resistance, most blood flow will go to the lower resistance circuit. So the normal parts of the brain, the blood vessels in the normal parts of the brain have to dilate like crazy to make sure they get enough oxygen and glucose and so forth to keep the brain alive. Well, when the blood vessels are dilated for a prolonged time, and this was prolonged because she'd had this AVM for a long time, it takes them a little while to be able to constrict appropriately so that with high blood pressure, you don't see too much blood flow to the brain, because if you have too much blood flow, you can bleed in your brain. Well, so after her procedure, we brought her back to the ICU, the neuro ICU, as I said, protected her blood pressure, kept it low to protect her normal part of her brain. And despite that, she bled into her head, bled into her normal brain, and literally died. She developed what's called brain death, which is death. Her heart was beating and her lungs were pumping only because we had a breathing machine on her, a breathing tube in her, and we're giving her drugs to keep her blood pressure up. So we had to tell the family this. Yes, your daughter came in under her own power, and now she's dead. It was extremely painful, and the family was just furious with us. They were furious. But she was dead. And so what the family finally asked for was that we keep her in her state, dead, in the ICU, on a ventilator, until her grandmother, who was out of state, could come in to say goodbye. Now, normally that's not a problem. And normally, as I say this, I'm like reliving this. It was just so miserable. I'm just not proud of this at all. Normally we would have done this. As it turned out, in that week or month or day, there were no beds in the whole hospital. Everything was full. There were no beds. There were no more beds in the ICU. And we had cases. This was a surgical intensive care unit, right? A neuro intensive care unit. Surgical intensive care unit. And we had patients coming out of the neurosurgical operating rooms that needed ICU beds. So even though the family asked for this, I said, no, we can't do it. We're going to remove the breathing tube, because again, she'd already been declared dead. And that's the end of it. And we did that. And it's not that keeping the breathing tube in would have changed anything. It wouldn't have. But what I could have done, what I should have done, and again, I've not forgotten this case, is I should have said, we'll do the best we can to try and keep her here till her grandmother comes. But if there's a case that comes out of the operating room that needs the OR, we will not be able to do that. And we will have to, we'll have to move her somewhere, probably removing the endotracheal tube, the breathing tube. And then we would have cleaned the room rapidly and brought the new patient from the OR into that room. I didn't do that. I just said, no, we can't do it. We removed the breathing tube and made what was a horrible situation for the family worse. That is a situation that I am certainly not proud of. Could have done much better, and I've never forgotten it, and have tried in all the ensuing years to never make that mistake again, and hopefully haven't. So things have gone well sometimes and gone poorly sometimes, and when they gone poorly, sometimes it's been the fault of me or my colleagues, and we try to obviously to minimize those and obviously not make the same mistakes more than once.
Those are really profound cases, and thank you for sharing those real world examples of what really went wrong. But on a good note, can you share to us what went right?
Well, the case of the judge is one that went right, and there are other cases that are similar to that have been challenging, but where the spending time with the family, the nurses and I, or my colleagues, spending time with the family, we have made what is a challenging situation better. Challenging because a loved one that perhaps they had no idea it was deathly ill, it had a disease that was going to take them, and they found out that was in fact the case. And we ensured that the family and the patient had as much support as we could possibly provide, that the patient didn't die alone, and that the patient died with some dignity. And there's more cases like that than there are cases that are problematic, by orders of magnitude. More cases like that. And it's what seems to me, what families and patients want are a couple of things. They want to know that we will push as hard as we can to get them back to the state that they were in the day before they came into the hospital or the ICU. But that if we can't do that, we will not let them die in agony, and we will not abandon them. Now, I know it seems like you might say, well, what do we abandon them? Who would do that? How could you do that? That wouldn't happen. But I'm so sorry to say that kind of thing does happen. And that's what they want, more than anything else, I think. They want some human touch. It's not just, yes, medicine is science, but it's more than science. It's because we're dealing with human beings, not small block Chevrolet engines. And so the key is to try and provide all of that for families. So usually things go relatively well, as long as we keep focused on those issues. The one final thing I will say, or not final, but in this sort of context, is when families ask us to do everything, and we say we'll do everything, we'll push as hard as we can, and there's still some unclarity, we will often say, now this is in the case of a stroke or traumatic brain injury or something like that, we will often say, it's unclear the direction your loved one's going to take. Let's do procedures so that we can feed them and keep them alive, keep them breathing if they can't breathe on their own, send them to a skilled nursing facility and give them a month or 2 months. And if things don't get better, we will bring them back to hospital or involve hospice and allow your loved one to die with some dignity. One of the other things that family members and patients are absolutely petrified of is that we will do the medical technology, that we will leave them with a person who is merely a shell of themselves in what's frequently called persistent vegetative state, where the patient no longer has the ability to interact. And the family will be saddled with someone who is no longer living yet not dead. And one of the things over the years we've come to is that we don't allow that to happen. We don't allow that to happen at all. And either get hospice involved, or we will get, or we'll actually help the families by bringing the patient back to the hospital if they've not improved, withdrawing everything and allowing them to die with some dignity.
Now let's talk about that hospice, Dr. Layon. So what can family member or a friend expect when placing their loved ones into hospice?
So the hospice movement starts in the 1960s with this incredible woman who was first a nurse and then became a physician, and saw her patients on the floor, cancer patients on the floor, dying in agony. She asked for permission to create a unit where she could take care of these patients in the hospital. And she created the first palliative care hospice unit in the world. Actually, this is now spread. This is now spread worldwide. Most hospice until recently at least, are not-for-profit community organizations where when the family is clear that their loved one is going to die, we contact hospice, they come to hospital, and either the patient would die in the hospital under the care of hospice with the family present, or better, either at home or in the hospice itself, which is a much more kind of homey environment than obviously the hospital is. The people who do hospice are magnificent for the most part, and what family members need to think about when this is going on is in the way that this is sort of made better, enhanced. First of all, is by before any of this happens, having had the family discuss end of life issues together before they ever show up to the hospital. To have an advance directive, if that's a possibility, a living will. So basically, to have someone who can, a healthcare surrogate, someone who can make decisions for the family member who's now a patient, when that family member, that patient, is no longer able to make decisions for themselves. In order to have that person, it has to have been discussed previously. What's their philosophy of life? How do they want to die? Where do they want to die? Difficult questions, but issues that absolutely have to be discussed in order to make this final journey, if you will, more humane rather than less. And in that situation, when there is a living will, an advance directive, and a healthcare surrogate, when the families have discussed what this patient would want, were they able to literally stand up from their bed, stand next to us, look at themselves in the bed, sick, and say, this is what I would want? That's what the healthcare surrogate does. The healthcare surrogate does not say what they want. They speak for the patient in their own voice based on the patient's wishes, which hopefully they've discussed in the past.
Now, of course, Dr. Layons, some family members would think that this may not be the right place for their loved one. So what would you say are the warning signs, that we might consider whether this is really, is this the right place?
You mean hospital or hospice?
I'm sorry, I'm talking about hospice.
Well, okay, so there's a couple of points. One main point is that certainly if a family is unhappy with the care, whether it's hospital, intensive care unit, or hospice, they can ask to be transferred to a different place. That is their right. The challenge in trying to exercise that right is that when you're as sick as you would tend to be if you were in the ICU or in hospice, it's very difficult to move to a different place. It's extremely difficult to find somebody who would accept you, right? A different institution would accept you, because you're literally in the hospice. You're dying. If you're that ill in the ICU, you are probably quite unstable from a physiologic standpoint. So it's really a challenge. Although we have at times found new places for patients when their families have been unhappy with us or with a different institution, but it is extremely difficult. It is true, though, it's also true that if we have a patient in hospice and the family says, this is just not what I want, or the patient, maybe even the patient begins to get better, they say, I don't want to be hospice anymore, they can rescind their the hospice orders, the fact that they're in hospice. They can be sent home with home health care often, and either get better at home or die at home. So there are some moves that can be made, but they're limited. And it's not limited because nobody wants to help. It's limited because when you're that sick, it's really a challenge to start moving around. The way to think about it well, certainly the way to think about it is in the United States, people talk about healthcare, uh, people who need healthcare, patients, us, as consumers, healthcare consumers, which is a term that I find offensive in the extreme. Like, if I was crazy enough to go to McDonald's and get a burger, which, by the way, I wouldn't, but if I was, I'm a consumer. I can go to McDonald's or Burger King or the local burger joint down the street. I can have a choice. But when you're sick, stroke, heart attack, car accident, traumatic brain injury, pneumonia, you name it, you don't have the option to sort of go doctor or hospital shopping. You are stuck with what you've got around you. So it's really, really quite challenging to think about patients and the health system in the consumer model. It doesn't really work that way. So when someone comes in dreadfully ill, and now we think that it's hospice is the appropriate move, and we set that up, and they go to hospice, for a family to try and go somewhere else is really quite difficult, frankly. For a family, if the patient begins to get better, to decide, well, maybe we want to try and get them home. That's often possible. That may be possible. But much more than that, it's really hard. It's also really hard when someone's dreadfully ill in the intensive care unit, when the family says, I want them to go elsewhere. That can be done, but it's really quite challenging. Healthcare is not, our patients are not consumers of healthcare in the way that we're consumers of groceries or cars or burgers.
Absolutely. Now, Dr. Layon, you shared to us some profound cases earlier, so I just want to touch on that. So, what would you say if a friend or family member is placed in ICU, they're intubated, and obviously they cannot advocate for themselves? Now, also if say, for example, they're not expected to survive, so what can we do to ensure that proper care is given for our loved ones?
So the keys are the things I think that I've sort of roughly outlined. So first of all, in the situation where the person who's sick, the patient, has previously written an advance directive or has an advance directive that says what they would want in the situation of a life-threatening illness where they were not expected to get better. We follow their wishes. If, in addition, hopefully, they've also appointed somebody as their healthcare surrogate. Now, that could be their spouse, a wife, a husband, could be a brother, a sister, a kid, or if they've got multiple kids, the group, the children as a group. They would speak for the patient, and they would help direct us when things don't quite follow normal course. And so that's probably the best situation. The situation that is more challenging is where the person who's now a patient has had some kind of random conversations with their family. Boy, I never want to have that happen to me, or boy, I never want to have life support. I don't like that stuff, or something. And then the family member, when the patient is now in the ICU, tells us what they've said. And as long as the family agrees and we agree that the patient's that ill, we would try and follow those rough instructions of the patient. Rough only because they're not put onto paper. More challenging yet is when there is never been a discussion, and this happens unfortunately too frequently, and nobody's been designated healthcare surrogate. And then we have to sit with family and try and figure out what the patient's quality of life was like for them in the weeks and months preceding the illness, what the family members think possibly the patient might want, based on any comments they would have made in the past. But that is the most challenging situation. So the best thing that any of our fellow humans can do is have the conversation, have, quote, the talk, unquote, with their family members about what they would want, if they're in a situation of where they might die, because it will happen to us all. but when they are. Hopefully, put it in writing. You don't have to have a lawyer. You can write it yourself. Have whoever was present and sign an initial, and the patient signs an initials, and we would follow that directive as well. And then have somebody appointed to have the patient appoint someone as their surrogate, someone who can speak for them when they can no longer speak for themselves. And the key, the central key of the person who speaks for the patient is no matter what that person feels or wants themselves as an individual, that's not what they're there to lay out. They may say, just keep my husband alive no matter what. That may be what they really want. But if that's not what their husband asked them to say when the husband was no longer able to speak for himself, they can't do that. They have to speak for the patient. What would this patient want if they could stand up, stand beside us, look at themselves in that bed, dreadfully ill? What would they say they want? That's what the surrogate speaks to. They speak for the patient, not for themselves.
Absolutely. Yeah. And I suppose it's really important that we think about these, these life events ahead of time so we can plan, so we don't pass the burden to our family members or to our friends. But we've been talking about the sort of death and dying from a medical perspective. But what I want to hear from you, Dr. Layon, is personally, what is your philosophy on death?
Well, I don't actually have a philosophy of death. I do have a kind of a philosophy of life that includes death. So if I may, and it's although I was once upon a time raised a Catholic, once upon a time thought I was going to be a Catholic priest, and so forth and so on. I'm not a particularly religious person in any way, shape, or form, but all of the great religions speak to service, serving and caring for one's fellow humans. In fact, and that's Islam, Judaism, Christianity, and it's also true in Buddhism, as I understand Buddhism. In fact, to my mind, the only part of the Bible, to my mind, that's mandatory reading for everybody is this section, Matthew chapter 25, lines, I believe it's 31 to 46 or 48, where basically we're instructed to take care of others the way we wish to be cared for ourselves. It's quite straightforward and simple. I think, we are randomly born into this world. I mean, we don't remember what we were doing before we were born. All we know is we woke up one day and we're here. And we will at some point die. And as far as I know, once we're dead, we're gone. The question is what do you do in the meantime? And I think in the meantime, again, in keeping with that admonition from the New Testament, but it does exist elsewhere, right? As I mentioned, Islam, Judaism, Christianity, Buddhism. I think our task is to make our world better. So, for example, there are, we know the situation in the world today. There are those of us who have sent our willingness to the Ukrainian government to be physicians, to create a MASH hospital for them in their country, or at least on the border with their country. There are those of us who do the same thing in the West Bank and in Gaza. There are those of us who have done work out of the country, as I have, in Nigeria, in Central America, and stuff like that. I think our task is to make our world better somehow, in the country, out of the country, because who are our people? Well, our people are any people, all people, right? I'm an American, but my people are as much the people of Nigeria as they are Nicaragua, as they are Japan and Germany. They're all our people. So I think the task is to make the world a little better when you leave it than when you found it, and then you'll die, and that will happen, and there's no getting around it. But at least you've attempted to make things a bit better.
Now, Dr. Layon, let's move on to a slightly different topic. Of course, as a doctor, as a medical professional, you were in the front line during the COVID pandemic. So Just give us like a ballpark figure of how many patients in your hospital passed away, and how difficult was that to deal with?
Well, I've had the fortune or misfortune, I'm not quite sure which, to be present at the for the three main pandemics that have hit us in the last roughly 50 years, I guess. HIV/AIDS, Ebola, and now SARS-CoV-2, which is often called COVID. Um, the you know with HIV, the thing that I remember the most strikingly, this is when I was at Cook County Hospital, that was most palpable was the absolute fear that we all had, because we had no clue what was going on. And I remember I was a very, very junior doctor at that point. I remember the senior doctors, not all of them, but way too many of them, walking away and saying, "Deal with this, deal with this." They were afraid, and the way they exhibited their fear was by walking away, and they left it to us, the residents. I think you guys call them in Britain registrars, to take care of the HIV patients. It was really quite horrible. With we eventually figured out what to do and what not to do, and and that was that. There's stories to be told about HIV/AIDS, but that's for a different time, perhaps. With COVID, the most challenging part of all of this was the unmitigated level of the level of misinformation, unmitigated politicization of this disease. Actually, it happened with HIV/AIDS too, and it happened with Ebola too. But it seemed particularly difficult and different this time. People denied that there was any such thing. They would come into the hospital dying, denying that they had anything, that it was just a cold. And the former guy and his minions. When I say the former guy, I mean the former president, the guy whose name I won't mention. Denied that there was any issue. It'll all go away. It was all China's fault anyway, but it'll all go away, and it's not really a disease. And the number of young people who I cared for who died, it was just breathtaking. The initial surge, it was said that there was something like 60% mortality if you made it into the ICU and had to be intubated with a breathing machine. With a second surge, it maybe dropped to 40%. But with a Delta surge in the summer of spring and summer of 2021, essentially, I mean, I've not run our statistics formally, but essentially, everyone who came to the ICU intubated, mechanical, a breathing tube with mechanical ventilation, died. Everyone. I think, 90%. And it wasn't just us. I would talk to my friends and my colleagues at University of Miami, University of Florida, other places. They were all having the same issues. It was breathtakingly horrible. You go into medicine and people will die. But I would watch especially our junior doctors and junior nurses. Junior only in the sense that they hadn't spent 40 years doing this, and they were damaged. They were damaged by watching our health system basically be on the verge of collapse, by watching our political leaders fight about whether this really existed or not. This would happen in the Middle Ages, maybe. That it would happen now is just unconscionable. And they would see people who did not need to die. One case that comes to mind, I just cannot get this guy out of my mind. It's a 39-year-old guy who came in, and he was sick, but not horribly sick at the beginning. And I would ask everybody, "Have you been vaccinated?" It was always no. And he said, "But I didn't think this was real. But I'll tell my wife and my kids to get vaccinated now. And if you get me better, Doc," he said, "I'll get vaccinated once I leave." And he died. It was 3 weeks later, but he died. 39. He was way too young. And there's case after case after case of that. There's multiple cases where, and this has been written about, where families become violent or on the edge of violent toward nurses and docs caring for their loved ones, because they don't believe that this is real. They've been told that this isn't real. On Fox News, it's not real. I mean, it's just this, that is what's been so horrible. It's like we're living in an age before science, yet we know exactly what's going on. And, you know, I've had teenage daughters, young women, teenage, I don't know, 20s, 21. I actually, it was all over the phone. I was told they were that young. Scream and curse at me because I wouldn't give their father ivermectin, a antiparasitic agent, which has no effect on COVID. And you know, I mean, does it? Of course, it affects. I mean, it affects me. I'm older. I've been around the block a few times, but where I really see it, what really worries me, is in our younger physicians and younger nurses. And people are leaving medicine and leaving nursing because they cannot deal with this nonsense anymore. I mean, let me tell you, I mean, sorry if I may, I know I've probably gone on for too long. You know, there was a young, one of the first patients with COVID I took care of was a 19-year-old. And he, over a period of about a month, got sicker and sicker and died. And when he was dying, his mom came to see him, and then he suffered a respiratory and cardiac arrest. He had a breathing tube in, but we couldn't oxygenate him. And so we spent over an hour trying to resuscitate him. And his mom watched the entire time. His mom was outside the room watching us do resuscitation, watching as I opened his chest to put chest tubes in. It's you know, like there was no way I was going to declare him dead without making sure that he didn't have collapsed lungs that were keeping us from getting his heart back. And then he died. And it wasn't that, and he died. He died because his COVID was so severe we couldn't oxygenate him. And when I went out, the mom was sitting down, and I was down on one knee next to her and telling her what had happened. She had watched it, of course, and she took my hand and she said, "Are you okay?" The kindest, most heartwarming act. Her son had just died. She watched us try and save him. Her concern was for us. You know, so there was that, as well as the threats of violence and the screaming and cursing. But the COVID has been just very, very challenging for everybody. Very, very challenging. And our cultural divides have not made it better in the United States. I don't know if you guys have that in Britain, but I don't think you do. But here it's been just horrific.
Well, when it comes to the healthcare system, obviously it's quite different because there's the NHS here, so obviously the healthcare system is free, but there's some parallels when it comes to, you know, especially with the COVID. There's also a lot of vaccine hesitancy, as you've rightly mentioned earlier. But I was just interested, Dr. Layon, were you frightened for your own life and the chance that you get COVID before the vaccine was developed, that you could also get sick and die?
I mentioned that HIV at the beginning. And I mentioned when I was a junior physician, what our senior physicians had, that some, not all, but too many, walked away, turned their backs, wouldn't deal with these patients that might be HIV positive. And one day, and I know you're asking about COVID, and I'm giving you a different example, but I just want to, this is a trajectory, and forgive me if I'm talking too much. But one night I was on call, and I at Cook County Hospital, we had a separate admitting ward. It was just a big area where patients from the ED would come before they were sent to the wards they were going to ultimately go to. And so I got a call at 2 or 3 in the morning. Your next patient is here. And I walk up, look at that. This is all, everything's on paper still. This is 1982 or 3, I don't remember. And it was a young guy who came in feeling poorly and was profoundly jaundiced. Now, I think at this point, we still weren't sure what caused HIV, AIDS. I think the virus may have just been identified, but it wasn't common knowledge at that point. And so I'm walking toward this guy, and I'm probably 100, 150 feet away from him. It's a pretty big area, but I can see him. And he's, although he's an African-American guy, black guy, he's as jaundiced as he can possibly be, just as jaundiced and yellow as he can be. And when I'm about 50 feet away from him, he sits bolt upright. He's on a stretcher, sits bolt upright, vomits, collapses in what was a cardiac arrest. Now I'm 25 or 15 and 10 and 5 feet away. And of course, I'm looking around. There's nobody there but me. Nobody. There's nobody. There was no masks to use. There was no nothing. I was just there. So I turned the guy on the side, cleared out his mouth, gave him mouth-to-mouth resuscitation, did CPR. It's been a long time. I'm pretty sure he died, no matter what. And at that moment, I remember thinking, as I turned him on his side, and as I cleared his mouth, I remember thinking to myself, I'm committing suicide. That if this guy had AIDS, I thought I was gonna contract it and I would die. And that would be the end of it. Fast forward to COVID, we knew relatively rapidly what the infectious agent was and more or less what to do. But I will tell you, every day, I believe in vaccines and I've been vaccinated and boosted. But even before that stuff existed, every day I would go to work in the ICU with all these COVID patients. And I expected that this might be the day that I get infected, get sick, and potentially die. I'm not saying that like I'm heroic, because I don't think I was just doing the job. I was just doing my job. As were our nurses, as were environmental service, as everybody was who came to the hospital, everybody. But that thought was never far from my mind. And in fact, two generations ago, maybe two or three generations ago, nurses and docs who went into nursing and medicine knew for a fact that there was a rock solid chance they would get infected with something, streptococcal pneumonia, meningitis, something, in caring for patients that would kill them. With the antibiotic age, that kind of disappeared, and it's now back. And so the surety that we used to have in the 70s and 60s, I guess, that whatever infection we get, we can take care of it. That is now gone. That is now gone. And there will be more COVID or something like COVID, right? Partially likely related to the climate emergency that we're in, with infectious agents we've never seen before coming to the fore. So there will be challenges, and the healthcare workers are at risk, as well as the people who surround us, our patients, our families, our fellow citizens. So it's a fear. Yeah, it's a fear.
And obviously that's perfectly understandable. Now, Dr. Layon, we're about to wrap up, so I just want to hear your thoughts about the U.S. healthcare system today, and also the insurance companies in America.
Well, you just said a moment ago that you've got the NHS and it's free. That was you said that, comma, and it's free. I will point out the national health system in Great Britain, in the UK, isn't free. It's funded with the taxes of the population, right? And I don't mean that in a pedantic way, but because that's what it's said here. Well, there's no such thing as a free lunch. Well, of course there's no such thing as a free lunch. The UK has a health system that's funded by the people of Britain and of the United Kingdom, because they view health as, in some fashion, as a right. I mean, I know the history of when it came into existence and why, but healthcare is determined to be a right. I know there's been changes after Maggie Thatcher, but in general, that system is a wonderful system. And in fact, in the Commonwealth Fund study of 2014, in which the health systems of 11 industrial countries, so-called advanced industrial countries, were I guess it just means rich countries, were studied, the British national health system was number one in the world. And of the 11 countries studied, the United States, the health system of the United States was number 11 in the world. We spent more than any other country in the world and had worse outcomes than any other country in the world. Now, I mean, I've spent my adult working life in this health system. I remember as if it was yesterday, standing on the quad at UC San Diego, and I was a 21 or 22-year-old, not in medicine yet, but thinking I was going to do medicine, arguing with some young conservative student colleague of mine about whether or not we should have some kind of national health system like the British had. It was the example that we were using at the time. And I argued vociferously, aggressively, that that's what we should have. And now, actually, 50 years later, I would argue even more strongly for a system. Bernie Sanders called it Medicare for all. You could call it anything you want. There are multiple ways to get to a system like that. The German and the Dutch have a slightly different way of financing their systems, but they're clearly, in terms of quality, safety, outcomes, access, better than ours. But we have to do something different. Our system today consumes roughly 20% of the GDP of the United States. Our total GDP in 2020 was about $21 trillion. $4 trillion of that went to healthcare. And with that $4 trillion spent, we still have something on the order of 60 million, 63 million of us who are either uninsured or underinsured. Uninsured, they've got no insurance. Underinsured, they work for somebody and they've got an insurance product that will pay out $1 or $2 or $5,000 per year, which doesn't even get you out of the emergency room. That's underinsured. And that's considered by our political leadership acceptable. That's considered okay. And I think it's considered okay because, quite frankly, I believe that our leadership doesn't give us a second thought. There are multiple examples. We do have the Affordable Care Act that Obama and his administration put into play. It's unwieldy, it's expensive, and frankly, it's a giveaway to insurance companies. We have a system that is just terribly archaic, terribly abusive to our population. It's not just that you might die. And, if you go to the emergency department and you're bleeding, they'll stabilize you. They'll take care of you. That's all good, even if you don't have insurance. And they'll admit you to the hospital if you need to be admitted. But then when you're discharged, you're going to have to pay for that. And, there's some controversy about the numbers, but something on the order of 60%, 600,000 people, 60% of bankruptcies in the United States today are due to medical bills or related to medical bills. This is just like inhumane. A civilized country wouldn't do this. So I've argued, lots of people smarter than me have argued for a national health system, perhaps similar to what you have in Britain, or something, but some system. There's been so much incursion by the for-profit sector, including private equity firms, into healthcare, that it probably we would have to do some significant manipulation of the way of who's allowed to own hospitals, who's allowed to quote own unquote doctors and emergency rooms. Even if we had a national health system, those are all discussions we will have to have. The example I would give, because in bringing up the private equity firms and private for-profit, not even healthcare firms that are involved in making a few bucks from healthcare, is the private equity guy that bought Hahnemann Hospital in Philadelphia. It had been owned by Tenet Healthcare for years. It's a private for-profit company. They hadn't invested in it. I was actually in that place. I was a visiting professor there. It was literally falling apart. This guy bought it, said, I'm going to invest money in it, and then decided he wasn't going to invest money, closed it, and I guess there'll be condos in that space now. He just closed it because he could. Because in our country, healthcare is not treated as a right of every human being that exists in our country, but as something that you can get if you can pay for it. And it is not what I think. It's not what we should strive to be like. So I've been a part of this system for my entire adult life. I know only too well what happens when patients can't afford health care. When I was the director of emergency medicine at the University of Florida, there was a group in the hospital legal system that when patients couldn't pay their bills, they would go after, put liens against their trailers. You don't call them trailers in the UK. I don't know what you call them. But you know what I mean? Trailers. It was really disgusting. And it remains disgusting many, many years later. This is not the way we should behave. So I'm not enamored with the health system. There are lots of wonderful people nurses, docs, you name it. We do good things. We do some amazing things, but the basic things, taking care of patients to prevent them from coming into the hospital with out of control diabetes, we don't do. Making their insulin affordable, we don't do. It can cost several $1,000s a month for patients to get their insulin. In Britain, it costs essentially nothing because it's not allowed. Banting and Best from Canada discovered insulin in the 1920s. They sold the patent for $1 because they believed that this was a benefit to all of humankind. And yet it costs some of our patients a couple of $1,000s a month to get their insulin. And if you don't have the money, you don't get the insulin. It's really quite pathetic. It's not the system I'm proud of by any stretch of the imagination.
Yes, and I could hear the passion in your voice that you're really longing for, restructuring of the healthcare system in America. But well, we have to wrap up now, Dr. Layons. I just want to hear your final thoughts for our listeners about death and dying.
Well, I mean, I think it's what I've sort of alluded to over and over again. The book I wrote is not specifically for folks in the United States, because medicine really is international, although there's some differences. For no matter whether you're in Britain or France or Germany or the Netherlands or Central America or it doesn't matter. To have had the discussion of what you want when the time comes that you're no longer able to speak for yourself and are sick, that really matters. It doesn't. Some people are afraid that it'll make the time come faster. If we just don't say it, it won't happen. Well, that's not really true. That's not true at all. So to have the conversation, to have what you would want put down on paper somewhere, so that you can show it to your nurses, your doctors, your whomever is caring for you when you do get that sick, and to have somebody who can speak to you. Speak for you when you become that ill. That really matters greatly. The other piece I would say is to come to grips, and it really is that strongly, I would say it, come to grips with the fact that we are just passengers for a little while on this incredible planet we've got. And although we all have problems, we all have difficulties, one of our jobs is to make our world a little bit better when we leave it than when we found it. And so to sort of, in whatever fashion we can, serve our people. And I've already defined our people very broadly. All humans are our people in my mind. I consider myself an internationalist, which is why I would work and have worked in the sections of our country that are deprived, as well as in the eastern provinces of Nigeria, as well as in difficult areas in Central America in the 1980s, and everything in between.
That's a lovely message to end this conversation, Dr. Layon. And it's really a pleasure having you here on the DRH show. But unfortunately, time is against us.
Okay. It's always against us.
It's always against us.
We'll lose in the end.
Yeah, I look forward to hearing more about your work. And again, thank you for reminding us that we have to embrace our mortality. Thank you, Dr. Layon.
Thank you so much, Dennis. Thanks. It's a pleasure being with you.